All right, I think we are just at the top of the hour and have a lot to cover, so we'll go ahead and get started. Welcome everyone to our medical providers update for the Fresno County Department of Public Health for December 16th. I'm going to go ahead and share my screen and just give you a lot of the updates that we wanted to share with you on this call. And then I'll be able to share out these notes a little bit later today as well. So can everybody see my screen on the Word document there? Hopefully you can. We'll just go ahead and start. So first, in terms of metrics and forecasts, things have been really strange with the state modeling and the state metrics. Because we look at the R effective, which is a metric of transmission. Whenever the R is greater than 1, it means that the pandemic is raging out of control, to use a very hyperbolic phrase. Whenever the R effective is less than 1, it means that the number of victims that it's finding is actually going down, which is good. So we always like to see the metric as being less than 1, and the lower the better. So it was really hovering above and below 1 during the fall surge, as you see here in the October times. And then it went way below 1 for the whole state, although we remained at a plateau level. And then as the whole state started going back up, people were really worried that what we're seeing is the start of a winter surge. But here we are, we're still at 0.9. So in terms of case transmissions, we haven't really seen it take off yet. Although in other jurisdictions, such as Northern California, Southern California, they're actually seeing a higher case transmission. In fact, they said between Thanksgiving and now, there's been a 47% increase in the number of cases overall. And those are mostly in Los Angeles and some of the Southern California counties, but also in Northern California counties as well. It is expected to rise because we know as soon as Omicron kind of hits, it's basically just going to take over. And we know that it's very contagious, and I'll talk more about that in a minute. So those numbers are why the California Department of Public Health passed this mask mandate, which I'm sure you've heard about. It went into effect on December 15th. It will last for 1 month until January 15th, and it's there to help flatten the curve. It's really, they want to strengthen all of the layers of protection in anticipation of a winter surge, which they're already seeing in other jurisdictions. So just to let you know that that's really what's driving some of the decision-making at the state level. And I'll talk more about the mask mandate if you have any questions. We're still trying to wrap our heads around it here in Fresno County. In terms of what our hospitals are doing, those are shown on this middle graph here. Currently, we have 190 individuals in the hospitals. Out of those, 39 are in the ICUs. Again, the projections moving forward show a plateau and possibly a decline. However, there's like big bold letters at the top of this page where I pulled this graphic from that say, Omicron will really throw us some curveballs. So take this with a grain of salt. So for all practical purposes, we're actually looking at this purple projected line, not this dark blue projected line, which is somewhat flat, but also rising. And we're expecting to have a rise and possibly a steep rise right after the new year as the Christmas holidays kind of catch up with us in terms of transmission. In terms of vaccinations, this is where we're at. We have about 54% of our residents fully vaccinated. Those are all residents. Out of eligible residents that have 1 dose, we're at around 61%, but 1 dose is not really that good protection. Even 2 doses are not great protection against Omicron. We really need people to have 2 doses and a booster. So that's really going to become the new standard to be considered fully protected, in my opinion, because the booster shots really do tip the balance in favor of human beings versus viruses whenever it comes to the Omicron virus variant. So please do what you can to get your patients vaccinated. Just let them know it's never been a better time to get your vaccine. Even if you've been vaccinated, there's never been a better time to get your booster and your flu shot also. In terms of Omicron, this is just taking over. I mean, it's been found in almost every state at this point. The CDC is just adding new states right and left. It's definitely more contagious than older variants, and probably more contagious than even Delta, which was already very contagious, as you'll recall. The doubling time seems to be about 3 days in some regions. And so that's why the percentage of Omicron jumped from like 0.9 to 3%. In some jurisdictions like New York and New Jersey, it's actually up to 10 to 25%. And it's really just creating a lot of outbreaks. There's actually congregate settings and school settings in California that have also been the subject of Omicron outbreaks. I'm actually very surprised that I can sit here today and tell you we don't have an Omicron case in Fresno County yet that we can actually point to. I'm just shocked. I'm sure it's circulating here in Fresno County. I just think that we haven't caught it yet. And that's just because of the delays in testing and the delays in whole genome sequencing, but it is just all around. It's basically in every neighboring county at this point: Kern County, Merced, definitely in Los Angeles and some of the Bay Area counties, et cetera. Now, how does the severity compare to Delta? Well, the articles that I've been reading share that people had worst case scenarios and best case scenarios, and neither one of those is coming to pass, that it's actually something in the middle. People are saying that there's evidence for a milder course of illness, but we have to remember that that evidence comes from a very select group of people, mostly college students in South Africa. And so it's hard to extrapolate that to people that are older perhaps, or less vaccinated, or have a lot of other risk factors, et cetera. So just keep that in mind, that we need to confirm whether the illness is really milder. And even if the illness is milder, the infectivity and just the sheer numbers are still going to create a surge. And I'll show you that in just a little bit. But just keep in mind that even if it's a milder illness, it's still not a picnic. It's not a walk in the park. No one is going to feel great when they get the Omicron variant. They're still going to have URI symptoms, sore throats, cough, cold, sneezing, et cetera. They may even have to go to the emergency department to get some IV fluids and some cough medicine. I saw that, over and over again this last weekend with lots of people who didn't meet any criteria to be admitted, but they were still just having a crappy weekend. And so just think about, if you extrapolate that out to hundreds of thousands of people that are going to miss work, miss productivity, create outbreaks that then shut down schools and other organizations. This really has the potential to cause a lot of disruption, even if, we get the very, very welcome blessing that it will not affect hospitalizations all that much. In terms of what vaccines are doing, vaccines work less effectively than, and that's why boosters really seem to help. And that's being shown by some of the companies that are doing some of these tests, and also more independent studies, because like I said last week, I really hate to rely on the companies for all of the evidence because obviously they have some conflict of interest about pushing their products. There's some other articles in here that I encourage you to go to. This is evolving very quickly, and I think that's part of the challenge. Is it feels like drinking from a fire hose, but I feel like there's more clarity week after week about exactly what we're dealing with, and I think a little bit more confidence about some of the public policies that you saw passed this week. In terms of the Omicron variant, here's a summary slide exactly from the CDPH. Basically, they estimate that the epidemiological parameters are still in flux. And that's just because it's hard to extrapolate from countries like the UK, South Africa, and Denmark to possibly a more diverse population like we have here in California. Any scenario modeling should be considered carefully. It appears that the variant is more transmissible or evades immunity more than Delta variant. Translation: the vaccines are not working as effectively. There's immune escape, or vaccine escape, as it's called. With substantial immune evasion, the pool of susceptible people could increase. So these are all the people that really did the right thing. They got their vaccine. Guess what? The vaccines are not going to be as effective. So you're going to see a lot more breakthrough infections. And that's why we need all those people to go back and get their boosters as well. So while there is some indication that the disease severity may be lower, it is important to consider that a high number of cases, even with a lower severity, would still impact and overwhelm hospital capacity. I can't reiterate that finally enough. Is that, even if it's just slightly milder, it needs to be a lot milder for us to be able to just rest easy. If it's just only slightly milder in terms of its virulence, then we're still in for a really hard time. This is the best data we have about vaccine effectiveness. And let me just zoom out a little bit so you can see the whole slide. Here you see that vaccine effectiveness wanes down, and then whenever people get boosted, it goes right back up. With the Omicron, it was very poor, but then it went up a little bit more substantially when people were for symptomatic disease. For hospitalizations, it's still very protective to get vaccines. However, that goes down also, and then comes right back up when people get that third dose or the booster dose. So that's why we're saying boosters are really no longer a luxury. They're not extra. They're absolutely necessary to keep people out of the hospital, and they will help to some extent, not a lot, but to some extent, keep people from becoming symptomatic as well. Okay, let me go to one last slide. This is actually the scariest thing that I'm going to present today, and this is probably what prompted the state to pass the mask mandate as abruptly and as clumsily as has been done this week. I don't think you could have asked for a more controversial and polemic public policy than what just happened this last week. But here we are. I think the state looked at this graph and just basically just said, we have to pull out all the stops. And then they passed the mask mandate come hell or high water. So what this shows is basically on the left side, you have basically if the vaccines and boosters work and Omicron takes over and there's no immune escape. Okay, so that's the best case scenario, that the vaccines and boosters work, we get them all into patients, and that there's no, and basically that's the best case scenario. This dotted line is basically where we were last year with the worst of the surge. So come January, guess what? Whether it's high severity, medium, or low severity, come January, we're going to see a speed bump here, right? It goes up. It doesn't go up as high as it did last year, which is great. But that's the best case scenario, is that we have a mild virus, lots of vaccines, and they work, and we have a very small hospital surge, okay? Here's a slightly more grim scenario, which is that the vaccines don't work that well, and for whatever reason, people don't get their boosters, or we just have a large pool of people that are just unvaccinated. Well, guess what? The worst case scenario is that this thing is really virulent, and it will just overwhelm last year's numbers. So remember that dashed line, it's 25,000, it hasn't changed, but they actually had to change like the log scale of the graph just to show you how bad this surge will be. And again, it will start taking off at the end of December and then really ramp up right after the new year. I think the state looked at this and said, if this is the red, if we're dealing with the red scenario, which again, it's hard to ignore that, then we're pretty much screwed at the whole state level. And I think they said, we've got to pass a mask mandate in order to protect people as much as possible, because we know that we need to use all the layers of protection that we could get. So I think that's really what prompted this mask mandate, is that the modeling shows that worst case scenario, that we're in for a really bad hospitalization surge just right after the new year. And they had to get on top of that with the holidays coming right up, to let people know that, even though we haven't seen a lot of cases of Omicron, and even though they are effective and all that stuff seems to be going in the right direction, the modeling for this that they have, and these are pretty smart people, they do this all day long. If this is the best modeling that they can come up with, and it just shows that it's basically just going to break all previous records, they have to act on it. And I think that they made the right call. So I know that all of us are fielding a lot of questions, and here at Fresno County, we've been fielding questions about the mask mandate all week, but I still think it was the right call. The messaging could have been done better. It appears that some Bay Area counties are getting exempted from the mask mandate, and that's actually not the case. It's just they happen to have mask mandates that were already in place, and so they're going to keep their old mask mandates. So they're not getting exempted. They're just getting exempted from this one because they already have one on the books that's still active. But again, that's a messaging issue, and that really doesn't apply to us because we didn't have a mask mandate. So now this statewide mask mandate does apply to us here in Fresno County and many other Central California counties. Okay, any questions about that? Hopefully that sheds some light. And this is part of a large slide set that I don't mind sharing out as soon as the state shares it, just about all of their modeling and predictions. But I think this is how the state is looking at making the best out of the data that we have as it's coming in. Any questions or comments or clarifications on that? All right. Let me move on to talk about some of the therapeutics. So monoclonal antibodies are still kind of our go-to for people that are close contacts or early COVID patients that are not yet hospitalized. So one question that's coming up is, how good are these things against the Omicron? Well, like with everything else, the evidence is still coming in and we can't make any firm conclusions. However, it appears that this sotrovimab appears to be more effective than some of the other antibodies against Omicron. However, remember, we're not in Omicron times yet. We still have like 99% of our cases are Delta cases here in Fresno today. So if you have patients today who need monoclonal antibodies, then any one of the monoclonal antibodies are going to be fine for them to get. Just get them plugged into these monoclonal antibody clinics that we have set up. Okay, don't worry about what's going on today. Just get them the monoclonal antibodies today, and the ones that we have today will work. In the future, when Omicron really takes over and becomes a dominant variant, we may be telling people, or smarter people will be telling us that we need to switch our strategy and not use all of these different monoclonal antibodies as if they're interchangeable, and really rely on one or another. And it looks like sotrovimab is going to be the one that's preferred until more evidence comes out. And some of the other antibodies like the Regeneron antibody, et cetera, may not be as effective against the Omicron variant. It's hard, right? Because we don't have the variant in front of us by the time we diagnose COVID. The variant testing still takes like 2 weeks. And you never really know whether your patient has the variant or not. It's really a population level assessment that the state is giving out. So we just have to make best guesses. But right now, you can bet money that the COVID patient that you're dealing with today has Delta variant. In the future, it will be 50-50, and then eventually Omicron will just take over. But that's still weeks away. So this is going to change week by week, and that's why I just said stay tuned. Okay, and our antibody document, which Dr. Zweifler has been very meticulously keeping, reflects all of that and gives you the best information and stays current. And he and the team look at that week after week to make sure that it's absolutely current and up to date. So thank you for that, Dr. Z. And then I'll talk about long-acting antibodies. So the one that's been approved with emergency use authorization is called Evusheld. And Evusheld is basically used for immunocompromised patients who just don't mount a good immune response in response to vaccines. And so for those immunocompromised patients, you can actually give them an injection of Evusheld, and that lasts for about 6 months. So it's pretty darn good instant protection for patients that are super vulnerable. The state has now made some initial allocations. We're getting just under 200 doses for our first round, and those are all going to go to hospitals. And by hospitals, I mean St. Agnes and Community Regional Medical Center. That wasn't our decision, so sorry, hospitals. I know the last thing you need is more patients knocking on your door at a time when you're severely overwhelmed, but that's just what the state decided. And I told them yesterday, like, please, in the future, work with us so that we can find a different place for these patients to go, because we don't necessarily need them to show up to the hospitals, especially if they're immunocompromised, to get this treatment. So hopefully this is just a couple of weeks, and then we'll have a different process that's much better for everybody. I know Dr. Bond is interested in doing this at the COVID Equity Project site. We're hoping to find other outpatient partners, possibly the same ones that are doing the monoclonal antibodies. It makes a lot of sense to just add this on to the monoclonal antibody work that you're doing. So we will work on this process. But for now, if you have immunocompromised patients, start reading about this product, start talking to them, start making a plan for how we can get them protected, and make sure that you don't let them fall through the cracks. Even though this is a pretty complicated procedure, we want to make sure we do our best to protect those folks. And we estimate that there's probably about 19,000 to 30,000 people in Fresno County that fit the bill of immunocompromised. And so that's the number of doses that we will need to set aside. And like I said, right now we have less than 200. So this is going to take weeks to months to work out, and we're working as fast as we can to make sure that we're doing it the right way. So please work with us and let us know how we can help you. And I'm sure that for some of you, we will be working with you to become sites where we can distribute this medication. And I believe it's an IM injection, but it may be an infusion. I'm pretty sure it's an IM injection, but it's one or the other. Unfortunately, it's not oral. And so that's basically how this is going to work. But it seems like a really important piece of the layers of protection that we've been talking about is to provide this 6-month layer of protection for people where vaccines just don't work for them. And then the last thing about therapeutics is the oral antiviral meds. So the molnupiravir is the first one that's in the pipeline. We still haven't heard when those allocations are going to drop, but those are going to be going to Rite Aid and CVS pharmacies, and then later to some FQHCs and other outpatient partners. The Paxlovid product, which is Pfizer, seems to show about a 90% effectiveness just based on their study. And so people are really excited about that one. The FDA and the other committees that work with the FDA still need to review it. And hopefully that'll get done, even despite the holiday schedule, because that one seems to be the one that people are most excited about. So we'll keep everybody posted on the oral antiviral medications as well. And that's really all I have for COVID news. Are there any questions or comments about any of those therapeutics? So what ages is Evusheld approved for use in? That's a good question, Daryl. From what I recall, it's either 12 and over or 16 and over. I can go back and check, or it's actually in that link that is part of this handout. It should be in this FDA link. So I'll double check that and see if I can track that down. But it's either one of those. I forgot the exact age. I think it may be 12 and over from what I recall. And then Lupe, I don't know which new COVID update you're talking about for workers and students. For the mask I don't know if you're talking about the mask mandate or some other update. Sorry, but happy to inform as best as we can. All right, if there's no other questions or comments, we're going to have our climate presentations from a couple of our emergency medicine residents. Is are Nate and Nikki ready to go?
Yes, hello.
Oh, awesome, great. Great to hear you both. I'm going to stop sharing my screen and then just introduce you. Dr. Nate Dreyfus and Dr. Nicole Palmer are both UCSF Fresno emergency medicine residents. We're so lucky to have them join us for today's Zoom and then present about climate change related health impacts and what we in our community need to know and how we can really come together for solutions to help protect our patients in our medical community. So take it away. I don't know which one of you wants to present first, but feel free to share your screens and teach us. Thank you.
Nikki, do you mind if I go first?
Go for it.
Cool, I've got a shift at 3, so that would be great. Let me share my screen. Okay. Is everyone able to see the slides?
Yep, looks
awesome.
Great.
Awesome. So I'm Nate. I'm a second year at UCSF Fresno, one of the EM residents. I have an interest in wilderness medicine. So when I was brainstorming my climate topic, I kind of overlapped the two a little bit. Within wilderness medicine, a portion of that is looking at morbidity and mortality related to animal encounters, including envenomation. So we're going to focus on just a little brief overview of climate change and its effect on envenomation. Though I will also kind of touch upon some of the other effects that climate change is having on morbidity and mortality related to animals in general. So sort of broad strokes, human-driven climate change is ongoing, obviously dramatic and far-reaching effects on ecosystems. As ecosystems change, so too will the ranges and the related species, as well as the behaviors and counts of those species. And these changes will inevitably affect the interactions of animal species with humans, especially given that expanding human populations means that sort of our interactions with the animal world are increasing. every day. Certainly as outdoor recreation increases, that's true as well. So animal sources of human morbidity and mortality. Obviously, in general, I think animals get the worst end of this interaction, but just for the purposes of this talk, direct human-animal encounters comprise a small but non-negligible cause of human morbidity and mortality. In the US alone, about 1 to 2 million ED visits per year fall in this category and cost over $2 billion. Globally, there's not great figures on kind of animal human morbidity, mortality in total, but we know venomous snakes alone account for more than 150 deaths each year, over 3 million annual snake bites from venomous snakes. Scorpion stings, 5,000 deaths annually on a global scale. And venomation events from Hymenoptera, which includes bees, wasps, and ants, in excess of 10 million annually. There's a significant disease burden from non-venomous bites, if you think about dogs, rodents, and then the impact of vector-borne illnesses is huge. Malaria, rabies, Lyme disease, you can go on and on. So if you think about climate change affecting the population of any of these sort of individual animals or categories, or especially the vector-borne carriers, you can see the impact on human morbidity and mortality can be pretty huge. So this talk will kind of start just with a narrow focus on one species, then a category of species, and then some takeaways from medicine in general. So brown recluse spider is kind of the individual species we'll look at as a representative species. The brown recluse is what's called a synanthrope, which means it's an undomesticated animal that kind of lives alongside and benefits from human populations. So it's kind of a fancy word for pests, right? Other synanthropes are the brown rat, which exists everywhere that humans do, essentially. Pigeons, raccoons in the Americas, in Asia, in some places, you'll actually find primates that are synanthropes. The recluse spider has a particularly nasty bite. The toxin is called sphingomyelinase D, which causes platelet aggregation, endothelial hyperpermeability, hemolysis, and neutrophil-dependent skin necrosis. Although interestingly, this necrosis only occurs maybe 20–30% of the time after bites. Rarely these bites can be fatal. About 1% of bites will result in some of the more serious complications: angioedema, acute hemolytic anemia, DIC, rhabdo, renal failure. Interestingly, there's sort of a really poor national awareness of where these things physically are. So on this map, you can see here the kind of top figure, the little gray area is where, according to specialists of the brown recluse, that's kind of where they are traditionally thought to have lived. But you'll get reports of bites all over the country. And interestingly, there was a survey a few years ago where they asked people to submit specimens of what they thought were brown recluses from anywhere in the country. 79% of the specimens that they got were actually not brown recluses. And interestingly, of the ones that they did receive that were genuine species, only 2 of those genuine specimens were from outside the known ranges. One was, in some moving boxes, essentially. The takeaway is that they really are pretty well confined to a small range, despite the fact that you'll have people reporting getting bitten by these and misdiagnoses of these all over the country. Certainly with the fact that people move and bring their moving boxes, it's always a theoretical possibility that you could diagnose a brown recluse bite in Washington state, for instance. The vast majority of the time, though, it's actually going to be a misdiagnosis. And just for some idea of scale, there's about 225,000 ED visits annually in the US for arachnids. About 3,000 plus of those are attributed to brown recluses. Another interesting sort of fact for providers on this call, to actually technically diagnose a spider bite, it has to meet 3 criteria. One is that the wound or the lesion has to be consistent with the spider bite, which is kind of the most inclusive. 2, the patient has to have witnessed the spider biting them. And then 3, the specimen has to be located and identified by a spider expert. So I don't know how many spider bites actually meet that criteria, probably a small handful per year, but you can see how the vast majority of these diagnoses don't actually meet criteria, which isn't a big deal, except that whenever potentially this is diagnosed, you're missing a more pertinent diagnosis, which could delay appropriate treatment. From up to date, this is just a brief list, and it's actually not brief at all, of medical conditions that have been or could theoretically be misdiagnosed as cutaneous loxoscelism, which is a fancy way of saying recluse bite. Loxosceles is the genus. So MRSA, that's probably the most often one that we see sort of confused for attributed to a spider bite. We get a lot of questionable spider bites in the ED in Fresno. Brown recluse spider. I'm going to introduce a topic called ecological niche modeling. So this is a very quickly rising and expanding area of study that basically is used to predict future distributions of species based on current data and machine learning algorithms. So what we see here, these maps are sort of an example of these in use, these ENMs in use. This is brown recluse modeling, a study in 2011 showing projected ranges of 2020, 2050, 2080. GARP and Maxent at the top are two different programs. The A2A and B2A are kind of conservative and liberal versions of climate change. If we look at Maxent, though, down in the A2A, which is the more liberal climate change model, we can see that the range of these has shifted significantly northward and expanded. And there's a tremendous number of studies going on doing ecological niche modeling for a lot of different species. And that's kind of the general trend, is that you see these populations, first of all, expanding as increasing portions of countries and continents are ecologically favorable, and then also moving away from the equator. So interestingly, in this 2080 prediction down here, you see that most of the reclusive are no longer found in their original range, as it theoretically has become too hot or other ecological changes have taken place. The way that the ecological niche modeling works is basically you take a lot of actual observations, and then included with those observations, the geographic location is a lot of data, ecological data, temperature, moisture content of the air, length of days, number of days of rain per year in that particular spot. And you put these into a computer, and basically based on a ton of actual inputs, the computer learns theoretically what is a good habitat, or what's a good set of variables that could produce this observation. And then it's easy to kind of transpose that onto a map of known geographic features, and then in turn transpose that on a map of predicted geographic features based on climate change models. So that's kind of a mouthful, but ecological niche modeling is a super useful tool for predicting distributions of species in the future. So moving on from the recluse spider, venomous snakes, we're going to kind of accelerate the pace at this point, just because I know we've got Nikki's presentation to get to also. So venomous snakes, every continent except Antarctica, they're ectothermic, meaning that they kind of rely on external temperature sources. Majority of their bites and deaths occur in subtropical climates, and that's kind of a theme. A lot of the venomous critters in the world, it's a technical term, exist in higher concentrations in tropical and subtropical regions, which isn't great news in terms of climate change. So increased temperatures in venomous snakes leads to increased activity, increased metabolic rate, increased digestive function, and a larger proportion of the day spent active. So predictably, when you warm up an area, on average, the snakes are going to be a little bit more active. And as increasing areas of, contiguous with their current distributions become warmer, you can see how venomous snakes would expand into that ecological niche as they're more able to successfully, hunt for and obtain prey, et cetera. So several studies, and there are dozens and dozens on these, have demonstrated expanding ranges for a lot of these venomous snakes. And the trend, again, is away from the equator, but with a net expansion. It's not like we're just kind of moving everything north, but staying the same size. There's definitely a net expansion. Interestingly, just one example of these many studies, this is 5 different types of venomous snakes within the country of Argentina. you can see these different colors on the map correspond with, where the range is stable. That's kind of this purple color. The orange is retraction of climatic space. So areas where, in this future scenario in 2080, this particular type of snake might not actually be evolutionarily, viable anymore. And then the blue is expansion. So in a couple cases, the net area for one of these species actually retracts, but for most of them, the net area increases, and what you see is a movement away from the equator, in this case, southward. Interestingly, into Chile, which currently doesn't have any venomous snakes. So I'm sure Chile won't be thrilled with Argentina about this. It's an already strained relationship. So this comes from a study in 2013 of venomous snakes and climate change. Ophidiism is a dynamic problem. And the other takeaway is that these are moving into areas of increased population density. Another study looking at venomous snakes in the Americas, this particular set of maps looks at copperheads in the US. And I'll just kind of jump to the takeaway over here on the right. Quote, a likely expansion of overall risk area and an increase of rural population at risk were observed from consensus model among future scenarios. Models suggest an additional 5.5 to 6.7 million people would be at risk for bites annually within the Americas. And that's at current population levels, not really taking into account increased human population concentrations. So more people are going to get bit. Just a really brief touch on some of the other areas where this ecological niche modeling is being applied. Ranges and distributions of scorpions, ranges and distributions of different types of Hymenoptera, which again are the wasps, ants, bees, which actually in the US account for the most deaths proportionately of venomous bites are from bees, hornets, etc. So anyway, this one paper, the title, Worldwide Ant Invasions Under Climate Change, which, almost sounds like a sci-fi title or something. Let's see, this is a slide just kind of highlighting how increased species range affects vector-borne illness. So this top line, a study in Canada 2019 about how there's been an increased risk of tick-borne diseases with climate change. Study in the middle here looking at climate change and global malaria distribution, which obviously the reach and impact of malaria is massive. So definitely an important area of study. And then the bottom, looking at climate change and the distribution of a rabies virus vector, specifically the vampire bat. And the interesting takeaway here is that in the next couple of decades, we could have vampire bats in parts of the southern US. So that's fun. The very large winged carriers of rabies. So why does this matter for medicine? This is a climate and health talk, and there's numerous ways. So human-driven climate change again alters ecology, which in these cases impacts directly epidemiology. Knowledge of true species ranges is important for accurate diagnosis and appropriate treatment. And this is true today, even within our country with the brown recluse, which is a fairly, well-known, well-established species. We've got people mostly misdiagnosing these all over the US when they actually, in fact, exist in a very well-circumscribed range, leading to, again, misdiagnoses and, delayed diagnoses and increased morbidity, potentially mortality. Another point is ecologic niches change, ongoing education of providers will be required. I mentioned earlier, there's 5,000 scorpion deaths a year. I don't know a ton about scorpions, because I don't see a lot of it, but certainly as these ranges change and the types of patients and risk factors present change, providers are going to need to re-educate. The availability and quantity of antivenom at institutions will need to reflect an evolving practice environment. We've got a handful of antivenoms available in the Americas. There's a completely distinct range in places like Australia, where they have venomous everything. And essentially we're going to need to have stock in the things that patients are going to be exposed to. And that takes time and resources and research to develop these and make these widely distributed and available and affordable. And lastly, public health campaigns, probably most importantly, are going to need to be dynamic to address these. Obviously malaria and tick-borne illness public health is kind of is entirely crucial in controlling the impact of those diseases. And as the ranges rapidly change, even in the last 10 years, the range of tick-borne illness has changed significantly in the US and Canada. Public health is going to kind of need to be nimble in addressing those. So these are my references. We've got some bonus content on identifying brown recluses that we'll probably skip. Just a really brief tidbit for those of you who can swear that you've seen them out here. There is a range of Loxosceles deserta, which are these ones up here, and those do exist out here. They don't actually live inside though. So if you've seen them inside, they're probably not brown recluses. Super quickly, they've got groups of 3 eyes instead of, so you can see 3 groups of 2 eyes instead of 2 groups of 4. Some more arachnid eyes for you. Okay, hope that was educational. Thank you very much for your time. Any questions very briefly?
That was fantastic. This is one of the most common things that I get called about, is people who think that they've been bitten by a brown recluse. And it's like, sorry, you got bitten by an MRSA spider.
Exactly.
Lead to a necrotic complication. And obviously it's very scary and does need attention, but people never want to admit they have bacteria, but they're more than happy to admit that they have spiders in their house, and they just blame everything on spiders. But and there's spiders that can bite and then basically introduce bacteria, which then go on to cause a problem. But it's not the brown recluse, necrotic arachnidism that you described. It's something else.
Mm-hmm.
Great, thanks, Nate.
Thank you.
Any other questions for Dr. Dreyfus? And good luck on your shift. Thank you for doing this.
Of course.
Your busy schedule. We really appreciate it.
Yeah, of course. Thank you.
Great.
All right. Thanks, Nate.
Go ahead, Nikki. Yeah.
Yeah, I'm going to try to share my screen. It has not worked in the past, and I have not fixed it yet. So yeah, does not look like it's going to work again. So I've already sent
I'll share. Yeah.
There we go. Tried to get ahead of the game here. Okay, so I'm Nikki Palmer. I'm also a second-year resident, along with Nate at UCSF Fresno in the emergency department. Prior to coming to UCSF Fresno, I was working on a pet project with a partner that was working in climate mitigation, actually. So we were trying to come up with a financial model that would incentivize healthcare facilities to adopt greener practices, basically lower carbon emissions. So that has since been put on the back burner, being in residency, but that is part of where this talk came from. I also used to work in refugee resettlement, so I have a strong interest in human migration and displaced persons. And in my glee for creating this talk, I actually ended up creating 2 talks in one. So I'm probably going to skip through some slides for the sake of time and go from there. Okay, so we can move on. I like maps, so I'm starting with a map. This I thought was pretty cool. This is a map of it's a niche. It is a climate niche for humans specifically. So Nate very beautifully described what it is, what these maps are. So I won't repeat what he said, but this is one that has existed for humans for the last 6,000 years. And the denser the green space, the more suitable it is for human habitability. We can go to the next slide. This is how things will start to shift. So, with the ICPP, or the Intergovernmental Panel on Climate Change, they fund studies to make these projections, and basically they use this metric of RCP, which is called a representative concentration pathway. It really doesn't mean that we don't have to really go into details, but basically it's a proxy for, okay, how bad are we doing? Like, how bad are things going to be? So this is like RCP 1.9 is the aspirational goal of the climate, or the Paris Climate Agreement. RCP 4.5 is like, okay, if we don't do so good, this is like the moderate outcome. And
so
then
that's the number of degrees that the world will warm. Is that right? Or
the RCP.
Okay, yeah. Is
No,
that okay?
It's a different proxy. It's a proxy for a different measurement, but
okay, got you. Okay.
Yeah.
Sorry. Go ahead.
Pretty sure. Anyways, and then like 8.5 is the most severe. So, any case, so this is the 2070. This is what is projected to be how our human climate niche will shift. It'll mostly just shift more north, particularly in the United States. And then if you notice, we can toggle back and forth between the previous slide and this one. Race, Dr. Vohra, there you go. Yeah. You can kind of see that in Central and South America, it starts to get pretty grim. And then if we go further, there you go. We go even farther north. So this is the 8.5. We go even farther north, and basically Central and South America basically become uninhabitable. So moving forward, this is another one of those projections when it comes to heat. So between 2040 and 2060, worst case scenario, this is, the denser the red is, the more weeks of the year that you have above 95 degrees. And we're somewhere around approaching between 17 and 26 weeks of the year, which is half the year. Moving on. So we care about this because both projections suggest massive upheavals in where we currently live and also grow food. That matters a lot, particularly in the Central Valley, not just because we are humans and we need food, but also because it is the main driver of our economy. So continue. So this is another sort of depiction of essentially a percent decline in farm crop yields. More purple equals more bad. So if you continue forward to the next slide, this is worst case scenario versus previously, and it's hard to tell the difference, but just trust me, just slightly worse purple in Fresno area. Yeah, okay, moving on. Okay, so a lot of people have said, well, throughout time, people have always migrated as climate becomes less favorable in different regions. And I always say yes, and also this has happened at an accelerated pace. That first graph was for 6,000 years, and now we're talking about within 1 century, these massive shifts. Also, we now have very strong political borders and power dynamics with those political borders that augment natural migration patterns. And as we know, climate change is a threat multiplier. So that means that you take your standard ills and problems that exist in a community, and then you just amplify all of them when you add in climate change. So that includes poverty, unrest, political, economic instability, and the sort and the rest. So migration often happens as a result of that. All right, moving on.
Yeah, kind of like a virus we've read about.
Yeah, kind of like that.
Okay, sorry, I'll move forward here.
I like it. I like the commentary. Keep going. Okay. We can skip through these. This is more of like, when people need to move, they become climate migrants. Although they're often called refugees, which is actually not an accurate term. That's because the refugee is very specific. It means it has a very legal and political implication when you meet this very specific criteria. And what that means is you actually get federally funded healthcare resources for people who are crossing borders, from fleeing from specific race, religion, nationality, and membership of a particular social group or political opinion persecution. Climate change is not part of that group, and therefore these migrants who may cross international borders do not fall into this category and therefore do not receive any federally funded healthcare. We can move on. I ended up talking about it. We can skip this and that one too. 2 examples. Okay, so the 2020 World Bank report actually came out with this 2021 statement that it projected by 2050 there will be 200 million migrants as a result of climate change. And That's actually a very recent report. And you wonder, the main reasons for that are water scarcity, decreasing crop productivity, rising sea levels, and of course, threat multiplier that we already talked about. Hotspots can be seen in the next decade. We need to work towards adaptation. So finding different ways to both help the people that arrive in the new place who have left their homeland, and also take care of the people who couldn't afford to leave, who are still left behind. And then lastly, of course, is mitigation. So mitigation is important because it helps ease the burden on the adaptation strategies, and it makes it so that we don't have to accelerate our climate, our niche destruction as fast. So moving on. We can move past this. Generally, all of this equals badness, poor health outcomes, overwhelmed healthcare systems, and sinking costs, as we are experiencing. So I wanted to then talk about this mitigation side. I'm really passionate about it. I'm a big fan of healthcare without harm. The president had this quote recently of, how are we ever going to support healthy people if the very sector of the economy that's committed to healing is itself a massive polluter? So turning the lens on ourselves, my favorite thing to do. So moving on. So this is the impact of healthcare sector on climate change. So globally, the healthcare sector, healthcare industry, that includes not just hospitals or actual patient care, but also supportive facilities and transportation and all of these different things, accounts for 5% of the world's carbon emissions. So the US healthcare industry is responsible for 25% of that. So we're a quarter of all of the healthcare industry of the world's emissions. Moving on. So what does that translate to? It's just numbers, it's just percentages. This is borrowing, the DALYs is borrowed from development spheres. And it's basically daily adjusted life years. And in our disability adjusted life years. And in 2013, the US healthcare's pollution wiped out nearly 500,000 years of good health. That's equal to 100,000 deaths. So it costs more than money to power and run our healthcare system. Moving on. So again, so what though? So if you take 25% of 5%, that 1.75% isn't that much. How will decarbonizing the US healthcare system, making it greener, help? Aren't there bigger targets out there? Well, moving forward, we're actually really uniquely positioned in an incredible way. Generally, we know that going back to basic economics, changing market demand is the most powerful tool for changing market supply. So if market supply is based on high carbon output, then changing the demand is a very powerful tool for if we demand that we have things come from low emission strategies, then supply generally will follow. The healthcare industry, the exciting part about the healthcare industry is that it touches many, many other industries. So power, food and transportation, construction, pharmaceuticals, technical medical devices, just to name a small selection. So if we change, we have tentacles in other sectors that also will promote change. And we're powerful enough to do it. We're 17.7 of the US's national growth, was it? Yeah, not GDP, GNP, the gross national product. So by 2028, we'll be 20% of the economy's market share. That's a lot of power. So in my mind, transforming the healthcare industry into a decarbonized state is powerful enough to transform every other industry that it touches. Moving on. So what do we got to focus on? Well, there's very smart people out there in public health departments around the country that have developed the greenhouse gas protocol, which tells us what's coming from where. So recent reports have showed that 20-25% of carbon emissions in the healthcare system come from direct energy consumption and emissions. So that's health facilities and purchase healthcare facilities, that's purchased electricity, among others. 70 to 80% comes from the supply chain. So goods and services used for construction, administration, medical devices, pharmaceuticals, and drugs that we use. Moving on. So knowing that, we can use this information to reshape healthcare as a model of environmental sustainability and reduced emissions. And has this been done in different places? Yes. So let's see, I have to pull it up real quick. But essentially, so we know that sustainability funds expanded care. The University of Arkansas for Medical Sciences basically they invested in building a central energy plant that was low emissions. In doing so, they were able to have an ROI, or return on investment, that added 60 new beds, a cancer floor, remodeled pre and post-op areas. They added 5 operating rooms and purchased 7 acres of land just by other cost savings with that central energy plant. Then we know that sustainability, like I just demonstrated, provides significant ROI, can be in monetary terms. Memorial Hermann Health System in Houston reported that they invested $3.8 million over 2 years in reducing carbon emissions through greener practices. Their ROI was $47 million over 5 years. Sustainability also improves resiliency and community health. So Kaiser, but I love Kaiser, but they in 2016, they implemented the first hospital-based solar-powered microgrid with battery storage. It powers their critical care services, even if the power grid and backup generators fail. It also invested in healthy, sustainable food grown locally. And by doing that, it's helping improve their community's health, which in turn saves them in long-term insurance costs. There are different forms of return on investment. All right, we can move on. And there's a lot of people who are really willing to help. So I have some questionable, companies on here, but those ones also have a sector in which is attempting to help in this regard. Healthcare Without Harm, I've already mentioned. Practice Green Health, I want to highlight this one in particular. They're an amazing organization. They exist in the US. They have been doing this for years. Basically, they hold any healthcare system's hand, hospital, building, whatever. They hold it through the greening process. They have access to all of their, any sector that any health system or building uses. They have contacts in there and coaches for connecting you to those resources to get you switched over. They also help you with developing an internal committee, people in the internal manpower and sort of organization that's needed to be built within a health system in order to facilitate and run creating these changes. So I just wanted to, I can't really do it, but if you go to their website, you'll see all the different sectors that they have their green fingers in all the different ways in which they've helped hospitals in the past become greener. It's really remarkable what they've done. Yeah, so in any case, moving on. Oh, there we go. Yeah, I was going to click on that, but I guess you can maybe. Let's see if
You want me to show everybody the website?
Yeah, if you could just, they have, oh yeah, so if you just toggle over those little circles down there, we can keep going. So there's buildings, they help with design, chemicals, they help with eliminating harmful chemicals, doing different initiatives in the community, helping reduce costs with energy, engage leader, they help with leadership, like I mentioned, there's food waste that they help with. So all these different sectors they're involved with.
That's awesome.
Yeah.
This is really cool. Hopefully some of our partners on this call will look into this and hopefully lead the way in terms of helping to decarbonize our local healthcare sector.
Yeah, you took the words right out of my mouth. Yeah, they're quite amazing. We were attempting to partner with them using trying to experiment with different financial models to help incentivize hospitals. Right now, they're using a subscription-based model where they basically fund this for the hospitals through membership. So each hospital has to, pay a membership fee, and then they receive all of these resources and all of the coaching and all of the organizational infrastructure.
Are they working in California, or do we know any local or statewide connections? The reason I'm asking is because, I'm sure there's people on this call that are definitely supportive of the idea, but then they are looking at the regulatory landscape and then saying, how are the state regulations going to affect us if we decide to move in this direction? It helps to have some examples across the state that then lead the way also. So I'm just kind of sharing that thought as well.
Yeah, no, that's a great thought. I'll from talking with them, it seemed like it was definitely a nationwide
cool
group, but I don't have specifics right now, so I would love to talk further about it and do some more research into that. Yeah,
and we want to help you. So hopefully we can, spark a conversation and a larger discussion about this. This is great. Do you want to finish out I think you have a couple more slides left.
Do I? I think it was.
We're at
this
time.
Was meant to be this is the call to action part.
Great.
Yeah. So we're powering U.S. healthcare system, expense of our future, which we, know. And then, most of our hospitals already have infrastructure and resources to go green and mitigate worst case scenarios. So it's just a matter of guiding them and providing support and filling in gaps where we need to. So that was the next thing. How can we help? What can we do? How can your facility take the next step towards this?
Thank you. That was great. Wow. Dr. Palmer, emergency medicine resident and future CEO. So please be good to me when you hold the reins of power. I mean, you're taking the big picture and you're really seeing the long view, and really appreciate your insights. It seems like you could probably, talk for a whole hour about some of the stuff that you've already done in your brief career with refugee and migrant health. So we really appreciate you educating us, and we hope that we can learn from you and collaborate together. So we still have our climate change collaborative. Our C6 collaborative is going strong. We actually were approved for a grant, so I'll talk about that next time, but we're going to be doing a local environmental resilience survey through the health department. So we're really excited about that. Dr. Palmer and some of her other co-residents are going to be helping us with that. And we invite the rest of you to reach out if you haven't yet to help us, because, this is a big topic, and it's a big, it really is, what they call a hyper object. It's going to take all of us to chip away at all of the different facets of climate and climate change and health impacts. And so it's always good to have these monthly talks to talk about the different aspects of it. So you and Nate did a great job. I know that we're going a little bit over, but I'm happy to stay on to see if people have questions or suggestions. Thank you so much, Nikki. All right, so lots to think about. We will definitely stay in touch. We may not do a meeting next week just because it's the start of the holiday season, but we'll definitely send out updates as we get them. We expect it to be a pretty busy week, honestly, with so many things happening around the new variant and with the hospital surge impending. So please keep an eye on your mail inboxes. Even if we don't do a Zoom, we will definitely try to get you information that you need to help you do your work. And aside from work, we hope everyone has a chance to rest and relax and recharge during the holiday season. Thank you all so much for your partnership. We really appreciate you. Merry Christmas and happy holidays. Thank you. Take care.